everyone who's logged in, and hello to everyone who's watching the recording. So what we're talking about this afternoon, or evening, or morning, or whatever time it is where you are, is paediatric dentistry, and really we're talking about managing patients during the COVID-19 pandemic. And so my name's Paul Ashley, and I'm going to start, and then halfway through I'm going to hand over to Susan Parrick, who's going to pick up the rest of the talk. So some basic instructions, I guess. We are recording the webinar, so if you want to watch it again, or if you want to share it with colleagues, then there'll be a download site on the Eastman webpage. And on the same page, we're going to put all the resources we refer to throughout the webinar. So talk about some different things you can download, some information, and that'll be on this resource page. We really want you to ask us questions, but the best way of doing that is to use the chat bar. So if you could type into the chat bar what your question is, at the end we'll work through those and we'll deal with the ones that we can deal with. Other than that, I hope you find this useful. Okay, so we live in a very different world to the one we were in last year. I don't think any of us could imagine that we would be working in the way we are working now, or how much our lives would change. And it's a really fast changing situation as well. You know, you think you've got some sort of certainty, and the next week there is a new government diktat, as it were, or there's something new that's been discovered. So things are really changing quickly. And the time span of all of this is really uncertain. You know, will we have a vaccine by Christmas? Will we have a vaccine by June next year? Will we ever have a vaccine? You know, how long this is going to go on for? We just don't know. And so we can't put life on hold. And at some point, we are going to have to start to resume elective care. And so really what we wanted to think about this afternoon was how can we resume paediatric dentistry? So who are we? Why do we think we should be talking to you about this? Well, Susan and I are both academics at UCL. We're also clinicians, and we work at the Royal National ENT and Eastman Dental Hospital. Okay, and so when the COVID crisis kind of kicked off, we rapidly had to turn from being a teaching hospital delivering elective care to what's known as a hot hub in the UK, which means that we see COVID-19 positive patients. And we're also what's called a UDC, an urgent dental care centre. So we've had to make a lot of changes and started to deliver care in a very different way. And now we're being asked to think about, well, elective care, because at some point in the next few weeks, really elective care will start to. And so we've had to do lots of thinking to get to the UDC point, and we're having to do lots of thinking to get to elective care point. And so we thought it would be nice to share our ideas with a wider audience, maybe because there are some things you've thought of that maybe others haven't, or maybe there are some things that other people have thought of that we haven't. So I think in these sorts of contexts, any kind of sharing is always a good idea. So what is the specific problem we're worried about? Well, there are two real issues. Dental treatment means people coming in. People coming in means people getting the train, getting the tube. It means them walking through the building, interacting with other patients, interacting with staff. And all of that will contribute to overall community transmission of the virus, which clearly we don't want. The second problem is that dentistry really means generating droplets or aerosols. What it's all about. And of course, this will increase the risk of transmission, just both to staff, but also to other patients. So how will paediatric dentistry have to change to minimize these risks? And we're going to give it from our perspective, which is teaching hospital perspective. And a lot of you may not work in a teaching hospital, and we acknowledge that. Hopefully some of what we say will apply to your own circumstance, but to an extent, we can only really talk about what we know. Okay, so what are the guiding principles? It's really important to maintain the safety of staff and patients. It's really important to prevent community transmission. But I think the big one is we mustn't lose sight of our patients. And it's really important that whatever we do, there is no detriment to the long-term oral health of any of our children, any of our child patients. So it's kind of like an escalator. You know, first question you have to ask yourself is, do they have to come in? If they do have in, can I continue to provide them the ideal treatment? If providing the ideal treatment might decrease the safety of staff and patients, or might increase the risk of transmission, can we give them a different treatment that's still evidence-based, that's still ideal, but it isn't going to cause these sorts of problems? And if you can't do any of that, then how can we stabilize the patient until ideal treatment can be provided? So what are we going to cover? Well, we're going to cover minimizing risk from physical attendances. We're going to talk about limiting use of AGPs in caries and in trauma. And trauma is when Susan will pick up. And then he's going to talk about managing emergencies, just touch on pain, extractions using IS. And then we're going to cover what we've learned so far. All right. What aren't we going to cover? We're not going to get into PPE. You know, essentially, levels of PPE are defined by WHO. There'll be national tweaks depending where you live. There'll be local tweaks depending on what hospital or service you work at. That's not something we can comment on. It's not something that we have any expertise in. As well, we're not going to really get into what is an AGP and what isn't an AGP. In terms of where we work, we follow the AGP definitions as set out by the Chief Dental Officer of Scotland. And just to summarise that, that means most uses of a high speed, or all uses of a high speed, sorry. Most uses of a slow speed, because with slow speed handpieces, they can get quite fast. And actually, I think the reality is that really using the slow speed at all is probably problematic. And using the 3-in-1 together. So pressing the air on it is okay, pressing the water on its own is okay, but using both together is a problem. And we'll just pick up on that in a couple of slides' time. All right, so minimizing risk from physical attendances. And we can think about new patients appointments, we can think about review appointments, and we can think about treatment appointments. So new patient appointments, and this really applies to people working in secondary care or tertiary care. So does a patient need to come in for a new patient appointment? And I think if you'd asked me that before this, I'd have said, well, of course they do. You know, how else can we do a full examination? How else can we take x-rays, etc.? But increasingly, because we've been forced to do a lot more telephone triage, a lot more telephone clinics because of the reality of the situation, starting to realize that actually some new patient visits probably can happen virtually. And I think part of this is expecting dentists or referring dentists or referring clinicians to give us much more detailed referrals. And actually, if a patient comes with an x-ray and comes with photos, sometimes it is possible to work out which clinic they should be, or to make a judgment as to whether or not they need to come in now or come back in a year's time. Okay, so I'm not saying that every new patient should be a virtual clinic, but I am saying that we need to really think very carefully about our new patient appointments, and maybe some of them can be moved to a more virtual format. I think when you're thinking about virtual, I think what is important is not to get too bogged down with the software you use, okay? Because there are lots of different apps out there. Certainly in the UK, we've got NHS Attend Anywhere, but actually you can get a lot of good information from a phone call and some good patient-taken photos. So I think don't get too bogged down with how you're going to. I think the important questions are which patients should be seen face-to-face and which could be seen virtually. So what about treatment visits or review appointment visits? So treatment visits, yeah, you can't do a virtual treatment visit. Clearly, they've got to come in. But how many times do they have to come in? Okay, so can you plan your visits so that they're more efficient? Can you make sure that you're having the fewest possible visits to get the most treatment done? Okay, do patients need to come in for a review? You know, or can the review be done over the phone? A quick check-in, how are you doing? How's it feeling? Is it changed? You know, and I think increasingly we're already doing virtual reviews, we're doing phone call reviews. And again, you could imagine with things like perhaps primary tooth trauma, does the patient need to come in, or is a photo that the parents take enough for you to gauge whether or not the tooth is changing colour or whether or not there's a swell? What about fitting appliances, things like simple Essex appliances or mouth guards? Does the patient need to come in for that, or could you post it out and then watch them fit it over the phone or using an app? And I think the other one that's interesting is oral hygiene instruction. This is one that our therapy school is looking at. So do you need to have somebody come in to be shown how to clean their teeth? Or can their parents prop the phone in the bathroom and can you watch the child do it using either an app or WhatsApp or Zoom or something similar? So I think there's lots of things to think about here with regards to minimizing risk from physical attendances. And for me, this is going to be one of the biggest of change. And I think when we come out of this crisis, I think we will probably do a lot more virtual clinics than we did beforehand. An important point is safeguarding. And I think all I'm saying here is don't forget about safeguarding, because I think one of the downsides perhaps of particularly a phone call appointment is you might miss some of those subtle cues that you might have as parent-child interactions. So I think I'm not sure I can say much more apart from don't forget about safeguarding. Okay, but I do think we have to be mindful of safeguarding and work out how we sure we are monitoring that, given that some of our visits might be more virtual than real. All right, so the next thing to think about is limiting use of aerosol generating procedures. And any of you who've done them using advanced PPE level 3 or whatever you want to use it will know that it's incredibly time consuming, it's difficult, it's expensive, it's a real faff basically. So we really want to do as few as possible. And so how can we change our treatment planning or change what treatment we do to still be delivering good, high quality evidence-based treatment to be sure that the child's not compromised, but minimize the use of HDPs. So I'm going to talk about caries in primary teeth, and then that's when I'll hand over to my colleague Susan, who will talk about trauma management in permanent teeth. And of course, before we think about treatment, we mustn't forget about prevention, and we should always remember caries prevention, but now is more important than ever. And it's really important that children are having regular fluoride varnish placement, that they're having all the things that are indicated in delivering better oral health. I think the one thing I wanted to pick up on was fissure sealants. Now, fissure sealants are probably still the best method we have of preventing occlusal caries. But obviously, to place a sealant, you have to use water to wash the etch off, and then air to dry the surface. And we're just speculating, if we've got a clinic with different trainees and students, etc., working on, are we worried there's a risk that they might inadvertently or just instinctively press the 3-in-1 button, that water and the air together, which of course equals an AGP? So one of the things we're thinking about doing is taking all the water out of the water bottles in the cart, which will mean that you can't use the 3-in-1 to squirt out water, and then everyone can have a little syringe of water and use that to wash the etch off, and then they can still dry in the normal way with the 3-in-1. But clearly, patients who need prevention aren't what we're worried about. What we're worried about patients who need caries treatment. And we're going to focus on primary teeth because we've only got a limited amount of time. And let's start off talking about children who've got no pulpal involvement. And actually, this is probably quite easy because, you know, we've got loads of evidence-based therapies already that don't require an AGP. And if you're not doing Hall crowns, really now's the time to start doing Hall crowns, you know, because in most cases you place a separator and then you place the Hall crown. You know, it's as simple as that. And I think this is really Hall crowns time to shine, if you will excuse the pun. So I think they are going to give us a lot of help during this period when we're wanting to avoid AGPs. Don't forget as well selective caries removal with hand instruments and an ART type technique. As long as you can get a clear margin around the caries, there's no reason why you can't do that. There's reasonable evidence for that. What I don't think you can justify is a conventional drill and fill approach. I really don't think you can justify that because the evidence exists for Hall crown and other approaches. I don't see how you can justify conventional crown preps anymore because we know that Hall crowns work and we know that they're as good as conventional crowns. And I definitely don't see how you can justify an aesthetic type of crown because it will require an AGP. And again, in terms of health, we know that Hall crowns work very well. I think the other change, though, particularly in the UK, because we've perhaps been a bit slow on the uptake with this, is SDF. And I think SDF has really got enormous potential to transform management of children with primary caries, particularly in this COVID-19 pandemic. So SDF is silver diamine fluoride, fairly widely used around the world. We've started using it in the UK. We started using it a couple of years ago, but probably used it in our department in a fairly haphazard, to be honest. It's an ammonia solution of silver and fluoride ions. It prevents, but critically, it arrests the caries of primary teeth. So that's what's different. It doesn't just prevent caries, but it turns the caries into this black hardened kind of mass that that the evidence shows is much less likely to progress going forward. It's usually about 38% fluoride, and usually annual or biannual application. And there's a picture there of the Viva Star box. Viva Star is probably the most common, or certainly in the UK, is the only manufacturer you can use to get STF. So good evidence base. In fact, it's probably got an excellent evidence base. And one of the concerns in the UK is that it's licensed for use as a sensitizing agent. So can we use it as a fluoride prevention agent? And if you want to read more about that, I'd recommend the BDJ article. I've got a picture of it here. We'll have it in our resource section, which explains why it's fine to use it as a fluoride preventive agent. It's really easy to use. You can fill over it. And the only risk you have to mention to your patients and their families is the risk of staining to the caries affected teeth. So the caries part of the tooth will go. And we haven't resumed elective care yet, but I think one of the things we're thinking about in our department is that every child that comes in with primary with caries affecting the primary teeth, both anteriors and posteriors, assuming the parents are happy with the notion of it going black, they should just have STF placed on that sort of first visit, because I do think STF will take us a long way to stabilizing these patients and even treating them, certainly throughout the COVID pandemic phase. Okay, what about if we have got pulp involvement? And involvement, again, I don't see how we can justify pulp treatment for primary molars. Because it's an AGP, and I think really extraction is the treatment of choice here. Clearly, you need to be worried about space loss, particularly with primary second molars with ease. There's always that risk of the six coming forward. But again, there's no reason why a patient can't have a space maintainer placed. A space maintainer just means an impression, and then some separators perhaps to fit it if you're doing a banded loop or if you're doing a crown type. And that's not an AGP. So I think there are ways of managing the space loss that don't mean that we need to do an AGP. Okay, so that is my bit done. I'm going to stop sharing and I'm going to hand over now to my colleague, Susan Parrick.
Right, I'm going to start sharing. Okay, and hopefully that all works fine. I'm going to move on and let's hope that that works. Great. So Paul has covered kind of the first bits about minimising risk of physical attendances and limiting the use of AGPs when it comes to caries. So I'm going to move on from that and now think about how we can limit the use of AGPs when it comes to trauma. And then I'll move on to talk a little bit about how you manage emergencies, with particular focus on pain, extractions, using IS, and then a little bit about what we've learned so far as well. So I think when we think about trauma management, it's really permanent teeth we're talking about here. I think there are three scenarios that we're going to sort of discuss and explore a bit further. The first one is, can we avoid doing an AGP at all? Great, if we can, that would be really useful. But there are going to be times where we will have to use AGPs, and then we want to think about, well, can we limit the number of times that we're going to be doing these AGPs? And then lastly, if we're doing the AGPs, how can we minimise the risk of the viral load from them? So I'm going to cover these now individually. First of all, let's look at one scenario where I think we're not going to hopefully need an AGP, and that would be splinting. Now, there's lots of guidelines out there for how to manage splinting. We've got the IET guidelines and so on, so that's all really clear. But I think it's really important that you consider, what type of splint you could use, because really you want something that's easy to put on, but really importantly, something easy to remove. And I think this is a scenario where the simple composite and wire splint is probably going to be easier to manage in this situation, in the current situation we're in, rather than say something like the TTS, the titanium trauma splint. And the reason for that is because when you're coming to remove this composite wire splint, you can use orthodontic bracket removers. And what we've found in department is the posterior orthodontic bracket removers, where they've got a sort of 90-degree bend, a bit like in the photo here, are really easy for just getting around. They kind of just scoop in under the composite and then you clip and it just pings the composite off really easily, 1, 2, 3, 4, off the teeth. And again, that means no need for an AGP. So that's a really good tip that we're certainly picking up along the way, and hopefully we'll be able to, some of you may be aware of it as well. Another scenario, so we've got a crown fracture and we've got exposed dentine. Now we know if we've got exposed dentine and we leave it, bacteria will just march in through that pulp, and before we know it, we've got compromised pulp in a tooth, and then we're definitely going to need an AGP to sort that out. So it's all about covering that exposed dentine. And this is a time where really you want to make sure that you've got a composite on there. GIC is not going to cut it on here because it's just going to be a leaky bond that's going to come off. So you want some composite on there. You can do it as your normal sort of two-step bonding with your bond if you're careful, like Paul was saying, about managing your 3-in-1 so that you don't inadvertently turn it into an AGP procedure. But if not, you can do that, or if you need to, you can use the one-step system, things like LPOP, where it's a sort of etch and bond combined. But I think you really want to make sure that you've got a composite covering. It may not be a beautiful build-up, but it's going to be there to protect the exposed dentine. Like I say, avoid the need for further treatment, and again, something that isn't going to need an AGP. So those are a couple of situations where we can avoid, hopefully, the use of an AGP. But clearly there are going to be times when we will have to use an AGP. And now we've got to think about, well, how are we going to treatment plan and manage these so that we're limiting the number of times that patients are coming in all the way to the clinic, exposing themselves, exposing us, and then we've got aerosol being generated. So if we think about non-vital, immature permanent excisors, something we see a lot of as paediatric dentists and we've treated children, you're really thinking about, right, we've got to really be following the guidelines to the letter of the law. We need to be thinking about the fact that once we've got a resolving infection, we want to get that dressed, filled as soon as possible, and no more repeated calcium hydroxide dressings. And I think as a department, we're probably a little bit guilty of that in the past, but it simply isn't something that we can do now moving forwards. So we know we don't want to keep calcium hydroxide in tooth for ages anyway, because we know it weakens root dentine, it's going to increase the risk of cervical root fracture. But most studies are suggesting that really once you've got calcium hydroxide in for at least a week and maybe up to 4 weeks, you really should have been able to disinfect that canal. And then in the absence of any clinical or intracanal findings that are suggesting there's still infection in there, you want to obturate it ASAP with a biocompatible material, something like MTA, biodentine, whatever you're going to use. Okay, and I think something that we've probably been a bit guilty of in the past is we've always thought if there's periapical area, we need to wait to see to get some resolution of that on the radiograph before we obturate. But the reality is we know it's going to take about 3 to 4 years for that bony healing to occur to us to be able to see on a radiograph. So that shouldn't be a reason to delay obturation. Only if the periapical lesion is getting bigger, that's indicating we're really not getting on top of this infection, should we delay obturation. Otherwise, once we're happy that the clinical intracanal findings are suggesting there's no more infection, let's obturate. Again, limiting the times we're doing AGPs for these trauma patients. And then another time where we've got to think about, you know, there's always that kind of and ahhing, oh, should we be dressing these with calcium hydroxide for a bit more, is where we're worried about teeth where there's a risk of resorption. And a classic sort of thing would be an avulsion or a severe intrusion. But I think, again, following the guidelines and what they're really saying, we should be considering obturating with a biocompatible material as soon as we can. Yeah? Because if we've got to think about it again, what are the benefits of these repeated calcium hydroxide changings? Once we've extirpated and we've got rid of that inflamed pulp, if we've got signs of no more intracanal or clinical findings, we should be waiting. So again, if we start thinking carefully about how we plan our procedures, we can think about ways to limit them. And then another way that we can think about how we plan properly and limit the use of AGPs would be a scenario where you've got an avulsed permanent incisor, and that can be an open-closed apex, but it's a delayed reimplantation. So it was out of the mouth 2 to 3 hours. So we already know that the PDL cells will be dead, the pulp cells will be dead. And normally, if we follow what the guidelines say, they would say that actually should be electively extirpating. So you would be thinking, well, do I do that the same visit that I remove the splint, for example, to try and limit the number of AGPs? Or should we be thinking, actually, in the absence of infection, should we extirpate and obturate in the same visit, again, so that we're limiting the number of AGPs? So these are things that we need to think about, and there will be subtle kind of differences to how we manage these traumas normally. But we know that if we're doing endodontics or we're doing composite build-ups where we're going to be polishing, we're going to need to use AGPs. There's no sort of getting around it. So if we think about what the evidence is suggesting, we know that if we're using rubber dam and we've got high volume suction, about 99% of the viral load is going to be reduced. That's got to be the gold standard for how we're doing AGPs for endodontics, and actually for most AGPs we can. If we speak to our endodontic colleagues, they're going to say that, you know, using Aerosol where possible, definitely to really isolate that tooth is good. And then certainly the British Endodontic Society guidelines are suggesting that we should consider disinfecting the operative area. So kind of swabbing the tooth with 5% sodium hypochlorite before we even pick up the drill to start the access cavity, to try and minimize the risk of sort of viral load all around. And then certainly what we're finding is that using apex floaters instead of having to use working length radiographs, so that we're not having to remove bits of the rubber dam, trying to get in a sort of a film holder and then having to then leave the room to take and develop the x-ray. We're trying to minimize all these things by using apex locators. So again, little tweaks that we can do to try and really minimize risk. So that's a little bit about how we can limit or avoid the use of aerosol generating procedures. But now we've got to think about, well, what are those situations where patients are coming to us with pain and problems and we're managing emergencies? So if we think about those, the first one that certainly we're seeing quite a lot of here at the Eastman are children complaining of pain. And so most countries are operating under the sort of 3 A's sort of scenario where dental practices closed and advised that really we should be giving advice, analgesia and antibiotics. But the problem with that is that we know that antibiotics are not indicated for pulpitis. And here we've got a quote from FGDP, you know, antibiotics of no clinical benefit in managing pain, and we know that. And we've done a quick sort of audit of the patients that we've been seeing since lockdown, and almost 50% of children coming into us needing extractions have already had 1, 2 or 3 courses of antibiotics. So clearly it isn't an effective solution for pain, pulpitis. And so when we're thinking about extractions, well, you know, when we had options of elective GAs, of general anaesthesia services easily, that was fairly straightforward. But obviously, certainly for us in the UK and other places as well, elective GA has been postponed. So now we've got to think of other creative ways of thinking about how we manage extractions in these children. And so we're finding ourselves in a situation where we're having to consider more using clinical holding. And by clinical holding, I'm not meaning sort of papoose boards sort of strapped down, but things like blankets for wrapping smaller children, using lap-to-lap holding, and involving parents much more in that, because we're trying to get these sort of extractions done. Certainly we're using a lot more inhalation sedation, and I'm going to talk about that a bit more about that in a moment. But I think don't forget good local anesthetic delivery. That's got to be key. And whether it's distraction, which we know evidence-based works really well for children, using things like the wand, whatever, but you know, if you get good local in, actually that's most of the battle won. And I've got here a flowchart for the BSPD website, which we've got links to in the resources, where it just sort of shows, you know, if you've decided actually you need to do this treatment, this child needs this extraction, they're in pain, there's been trauma, the next really key thing to think about is the parent going to be happy to go ahead with this? Are they on board? Because if you have a parent on board, and because they're the ones who are going to be doing holding, then it's probably going to work. But if they're not, then it really isn't an option. But I do think we have to start looking into these things a bit more now, like I say, because we don't have the option of GA. But just moving on a little bit to think about inhalation sedation. So there's been a lot of confusion about this in this current period of the COVID-19 pandemic. And so 2 of our colleagues here at the Eastman, Isabel Holroyd and Praveline Anand, who are expert sedationists and paediatric dentists, put out this really nice blog sort of updating on where we stand for inhalation sedation. So I've got a little summary of it there for you. But I think what the key message to come across is that it's a safe and it's effective method of managing children and reducing their anxiety, and we should definitely be using it during this period. You know, particularly without GA, it's got to be something we use. There were 2 issues with inhalation sedation that keep coming up. One was, is there a risk of contamination of the equipment? Can you kind of rebreathe through the bag, and can it go through back into the machine? And so my colleagues were in touch with the manufacturers, and it's really clear there is no rebreathing back into the bag or through the back into the machine. So if you're following your normal cross-infection procedures, there is no risk of contamination. So that's good. The second thing is a little bit trickier, because it was, is IS considered an AGP because of it being sort of high flow gases and things? And this one's a bit trickier. We've been in touch with our infection control, with virology, and really the evidence to say it's an AGP or not is lacking at the moment. Like so many things about COVID at the moment, evidence is just building the more we get to know about this disease. But I think here in our trust, we've sort of taken a precautionary approach. We're just assuming that it is. So that means it has big implications for our service delivery, but that's the sort of stance we've taken. Those are sort of discussions you may be having in your own sort of local areas, thinking about using IS. But I think the key message I'd want to get across is that we should be using IS, particularly for these during this period for anxious children who are going to need extractions and treatment. Okay, just to finish off, what have we learned? Well, I think some things we've realised is if the children are coming to see us for the very first time and they see us looking like spacemen with all the sort of full PPE, it's quite scary for the children, for the families. So we've learned that it's probably a nice idea to try and prepare children where possible. So this is a poem that was developed by colleagues in Birmingham Dental Hospital and Children's Department, and also the illustrations were done by one of our postgraduates, Jasmine. But this is a little leaflet which just gives a little idea of what people are going to expect when they come in to see us for the first time. And we try to get this sent out to the parents and families before the children come in to see us so that they know what to expect. And I would say at this point on the British Society of Paediatric Dentistry website, there's a lot of really nice resources for how to prepare children for coming into treatment and about the COVID period. So do please look at that. There's a lot of good information there. So what do we find? So when people come in to see us, first of all, what we like to do ideally is not be in the full gear when we see them for the first time. So what we do is what we consider here in the UK as level 2 PPE. So that's a disposable apron. We've got a surgical mask and a visor, and that's where we greet them and see them for the first time and do the initial assessment. And so it looks a little bit less scary than a kind of full-on sort of spacesuit astronaut. This is where we'll do the exam assessment, we'll take radiographs, and we'll do any consent for, say, extractions, IS, and so on. And there's a lot of sort of discussion about, should we be avoiding intraoral radiographs, particularly if we're worried if the patients are going to gag and cough. And I think if you have got someone that even on examination you can see it's quite difficult, then you probably want to consider that. But I think it comes down to, again, it's what's the best benefit for the child. It's all about our sort of IRMA. We've got to think about what is the most appropriate view that's going to give us the best information. And that should be what we should be doing. Likewise, we also want to kind of think about what's the foot flow going to be if we're sending every patient down to X-ray department when we can take intraorals in the chair. So all these sort of things we're having to consider and tweak as we go along. If we do need to do an AGP, well, then they become far more exciting. So we'll normally get the patient parent to wait outside while we get prepared. We have a separate area in the clinic where we do the donning and doffing. And then we've got to have the two people involved, the nurse, the dentist, and someone else who's going to be sort of preparing them and going through all the stages with them. The surgery, we need to have it prepared, so we really need to know what we're doing beforehand because we need all those instruments for that procedure in the room. What you don't want to do is be going in and out because every time you open the door, you might let viral particles out. So we've got to kind of be really super organised. And it takes about 20-30 minutes. Like I say, you've got to really avoid opening the door during the procedure and until the viral particles are settled. So those are where we use things like apex locator rather than, like I say, taking a working X-ray and then having to open the door, go out and get it developed. The other thing about having waiting till the viral particles are settled means that, depending on when you finished your AGP procedure and depending on the flow of how air exchange happens in your room, in your clinic, you will have to then sit there for a little period of time while the viral particles settle onto surfaces so that then they can be cleaned easily. And that means that clean will be sort of in between patients and then a big clean sort of at the end of the day. So what we've worked out is that really each AGP is taking us approximately 2 hours to do. So you can already see what sort of impact that will have on just elective procedures moving forwards. Other things that we've had to consider, how are we going to plan our clinics? When we start to resume normal-ish service, how will that look? Well, we already realised we're going to have to stagger appointment time because you can't have everyone turning up at the same time because we won't be able to maintain social distancing in the waiting area if they're going down to X-ray, even if they're coming through a door. So all these things are having to be really worked out carefully. We have a large sort of main clinic, open clinic, where we do see most of our patients, but now we've realised that to maintain that sort of 2-metre rule, and think about the number of people that would be in the bay, which is both the dentist, the nurse, patient, parent, possibly a sibling. You know, that's a lot of people in there. So we've realised that already for us to be able to maintain social distancing, we're going to be looking at using alternate bays. Again, having big impact how many patients we'll be able to see in a day. And then what we've noticed is obviously for AGPs, we've got to really identify these procedures in these patients. So we're having to triage all our patients' lists to see who's going to need an AGP so we can plan appropriately, because they have to happen in a closed surgery, in a more closed environment, and we don't have that many of those. So we have to really plan those properly. And we've had to remove everything out of those rooms that we don't need in there and cover everything that can't be easily cleaned. So really lots of sort of things that you've got to organise, things you didn't have to think about before that you've really got to rethink now. And certainly for us as a teaching hospital, we've really had to think, how are we going to manage supervision? Because before we would normally pop in and out and things were going at each stages, we can't do that now at AGPs. So lots of planning involved in how we move forward. So I think in conclusion, I would say we are learning and we're having to how we provide care in the COVID-19 world. As Paul said in the beginning, I think until there's a vaccine, this is our reality, so we're going to need to get on with it, basically. There's got to be a focus on prevention. If we can do that and avoid anyone coming in at AGPs, great. But I think there will be lots of times we do have to do an AGP, and we need to have a plan for how we're going to manage moving forward, whatever service you're working in, because it will be changed. Okay, great. So that's done there. So now I'm going to stop sharing. And then what I will do, it sounds like there were comments. So I'm going to try and go through some of these. I think Paul looks like he's answered some of them already. Okay, so it looks like Paul is... Paul, so you've kind of answered a few as you've gone along. Is there anything in particular you wanted to highlight?
So Jennifer's got her hand up. Jennifer's got her hand raised. Good. So here comes some questions. Very good. And Jennifer, if anybody wants to post their questions, just post away, and then we'll walk through them. So Susan, I'll let you start.
So there's a question here from Sarah saying, what is the consensus on air purification of a clinical area between patients? Is the focus mainly on specific fallow times and increased surface area cleaning? And then has something, I'm not sure. So my understanding is that it really depends on the air exchange in the environment that you're at as to how long you need to wait for the droplets to sort of settle before they can be cleaned around in between. So even in our hospital on different floors, we have different air exchanges, so that's how it equates to different times. So I think you're going to need to find out, Sarah, in your situation, what is that air exchange, and then that will give you an idea of how long you need in between patients. So hopefully that will answer that one. Sharmila was asking, wouldn't a cough generate an aerosol as opposed to droplet? So again, this was something that we queried, and when we queried it to our infection control, the answer we got back was it would be a droplet as opposed to aerosol. So that's what we're going with. Like I say, Paul and I are not infection control specialists, so we're letting the specialists tell us what it is. Farha's got a question about off-label use of SDF. Does it need recording in notes and permission of parents? So Paul, I'll let you answer that one.
Yeah, so no, totally. We have an information sheet and we normally take consent. And if anybody wants copies of our information sheet, then just ask me and we can either put it on the resource page or I can email it out to you. And we've just contacted one of our old students, Rashid in Singapore, who's been using this for a long time, and we've asked him for some clinical hints and tips because like I say, we are using it sporadically, but I think now we need to move towards really using it almost every patient who comes through the door. And I'm just going to jump to for her second question, and then I'll let you answer Siobhan's question. Any chance you do a seminar on how to use SDF? Or maybe for you, Farha, assuming you're the Farha who I think you are. We can think about that, sure.
And Siobhan's question was, minor point, sometimes bracket removers, I worry I might impact PDL healing through luxation end use. Yeah, so I think initially, Siobhan, I was also worried. I was like, oh, what if you're going to really press hard on the tooth? Is that going to damage it? But actually, having seen it now being done a couple of times, it's really easy. It just clips off. Yeah, it really doesn't require any force at all. So no, I'm now less worried about that. I mean, clearly, if it's you try it and it doesn't come off, you're going to have to plan B, AGP. But I'm surprised it comes off really quite nicely with the bracket removers. So I would definitely say give that a go. And I think that's something we would probably use routinely moving forwards because it's so much easier.
I'll answer
Yeah.
Shamila's question. So yeah, so this whole off-label use thing, I mean, it is an interesting topic. I think I would suggest you read the BDJ article, the one that I refer to, and it'll be on our resource page. That outlines why it's okay to use it. Yeah. Yeah. So I'd suggest you read that.
Good. Any other questions, anyone? No, looks like we've stunned you into silence. Oh, no, here's coming for you. Okay.
Yeah, so Furha, the link,
Yeah.
I think, so I think if you go to the Eastman front page, you should see a COVID-19 resource box, and it should be in there. We'll chase that up, probably give them a day or two because they'll download the recording and then put it on, but it should be there. Our emails on the website, within reason, there's 41 people on the call, so within reason you can just contact us and we'll give you information. I don't think it's going to be too difficult. Yeah, so Libby, consent for STF, the consent form is the standard consent form, but I can share the information sheet. And actually, Kate Ma, if you're listening, can you remind me to upload our information sheet to the resource page and then everyone can just grab it?
Yeah, okay. No problem.
Brilliant.
Yeah. So Sarah's telling you the links will appear tomorrow on Monday. So hopefully you'll be able to see the links there. I've heard of a unit avoiding reimplanting of false teeth as a result of avoiding AGPs. Surely that should not be happening for you. The presence of, yeah, I would suggest so. I mean, if the indication is that you should be reimplanting an false tooth, then you would do that. You know, you still carry on.
Yeah.
It's just like I say, the issue becomes if it's delayed reimplantation, then you've got to think carefully. It may be that you decide to root fill it in the bench and then put it in. So those are different things that you would think about, but it shouldn't, you know, at the end of the day, as Paul said, it's all about what is the best management and no detriment to that child, and that always has to apply no matter what.
And to pick up on that, Mariam, actually, I don't see why you can't replant a tooth without an AGP. Putting it in, not an AGP, splint placement, not an AGP, splint removement, not an AGP. And I think the consequences of not replanting, let's say, a central incisor are so profound for the rest of that individual's life that even if you did have to do an AGP, then you're going to have to do an AGP. It's not that we can't do AGPs, we can do them, we can do them in a safe way. It's just we want to avoid doing them because they're so time consuming, costly, and just if you've had to do it, difficult. So do you want to answer Sharifa's question, Susan?
So with regards to stopping resorption, what should we use? So I think the reality is, Sharifa, you know, if resorption is happening, it's happening. What we can try and do is stop inflammatory resorption by extirpating the pulp, because then we get rid of that inflammation. But if it's happening, if you're getting replacement resorption, calcium hydroxide isn't going to stop that. So you may as well get it infection-free and then put a biocompatible obturation in there and then deal with what happens beyond that point. But, you know, we don't have a magic medication that stops all forms of resorption. I've heard of not replanting teeth also. I think this might be difficult to justify. Adults might be a different story. I think, you know, I think our feeling is strongly that, as Paul says, actually reimplanting a tooth, splinting, taking it off, none of that needs an AGP. It's just that you've got to then, and even if you do that, it's still buying you time to then find somewhere to get them when they need the AGP for whatever the rest of the treatment. But I think if it was me, I would want that tooth put back in, and if it was my child, I would want their tooth put back in. So that's what I generally, the principle that I operate on. Should we fill the whole canal of MTA? I think it's, I mean, MTA, Bidentin, whatever you're using, yep. Obviously, there's the issue of MTA, and if you go beyond CJ about having discoloration, so you may want to use alternatives, but MTA obviously still has the best evidence base beyond it. Okay, good. Yay, people agree with me. See, avulsions, those teeth back in. Reality is children cry, cough, spit blood when we haven't planned an. Is this a risk to staff? Yes, I mean, that's a good point, Sergey. And I think this is where, you know, if you're thinking about doing something and you're anticipating it's going to be a child who isn't going to be particularly cooperative, then actually, you know what, plan it as a AGP. Think if I'm going to use IS because I want to stop lots of screaming and crying, whatever, then just plan it ahead and plan it appropriately. What you don't want to get is halfway through and go, oh, this isn't going to plan. Now we're going to need IS. Now we're going to send them out for half an hour, because all the behavior management is all going downhill by that point. So I think it's where these are skills as paediatric dentists. You know we can judge pretty well how our children can react. And if we think this child is going to need an AGP because it's going to be IS or whatever, then let's plan for it and do it properly.
But just a point, cry, cough, spit is droplet, yeah? So if you're doing extraction and you're not using IS, at the moment, what we would do is we would not treat that as an AGP, it's droplet risk, and we just take the tooth out. And actually, that's what we've been doing now. Now, whether or not we are doing the right thing, I can't tell you. All I can do is say we are doing that for this reason, because crying, coughing, spitting is not an AGP, it's a droplet risk. So therefore we would do it with level 2 PPE. And even IS, we're treating it IS as level 3 because we just don't know. But even IS might turn out to not be an AGP. And I think the interesting one is if you look at maternity wards, they use Entonox there like it's going out of fashion, and they're not treating that as an AGP. But just to go back, cry, cough, spit technically is droplet risk, not the other one. And Furha's got a good point after that, Susan.
Yeah, I'm just trying to go through. So is parents holding, clinical holding, is this cross-infection? No. So the same way that we're saying that, you know, the parents are the ones living with the child. So if they're the risk, then they're with that child all the time. So there isn't an issue about cross-infection risk that way.
And just to hammer home that point, Furha, we have a COVID positive zone in the hospital. That's down in the basement where you go if you've known COVID. And if a patient came with the child there, the protocol was the patient wouldn't wear a mask, because if the child's got COVID and they're living with the family, as Susan says, then the parent is already at risk from COVID 24 hours a day. Yeah. Sharifa, I'm forced to see kids under GA now.
Yeah.
Well, I'm glad you got GA, Sharifa, because that's one thing we're struggling with.
Oh, yeah. So but I think that is a reality. If we don't get on top of this and start doing stuff, we're going to have more and more children with multiple abscesses and needing GAs, and certainly for us where it's an issue, that's why we're really having to be proactive and trying to get these children seen and seeing what we can manage, because otherwise we are just sitting on tip of an iceberg that's just going to explode. Anything else? So
Furha, only using clinical holdings or extraction, same thing.
Yeah.
Sarah Jane, droplet risk is still COVID transmission risk, but it's level 2. So droplet, and this is what we are doing. Droplet is via an ordinary mask and apron.
A disposable apron.
Yeah. So that's what our staff and trainees and the odd student actually are wearing to take teeth out on children. So one of our students is from Greece, and they don't have much access to GA there, so she's got pretty good clinical holding skills, and she's been using them to full effect over the last few weeks, because obviously we've had some emergency patients we've just had to crack on and get the tooth out, and it's not been what we'd normally do, but what are you going to do? Okay, I think we're done now.
Yeah. Oh, okay, great.
And so like Shema, is that you, Shema, or is that a different Shema?
I'm thinking it's our Shema, but yeah.
Okay.
Oh, looks like Liz.
Oh, Liz, please just type away.
Yes, please do.
I think if everyone just types and posts, it's probably easier that way.
Yeah, Sharifa, don't worry. There will be a link on the Eastman website. And like I said, I think it's going to be shared on social media as well. It will be on our different sort of Facebook, YouTube, Twitter, and so on. So don't worry, there'll be plenty of opportunities. Good. Well, I'm glad you guys found it helpful. Yay! Very nice to see some of the faces, names of our previous sort of students, which is lovely. Llama as well. Yes, very good.
Excellent. So
Liz,
Liz, are you typing? Type faster.
Or maybe just raise your hand to say hello to us.
Yeah, no. So I think that's a nice point about SDF. Well, we might, Kate. I mean, maybe we could do something short and sweet on SDF. I almost feel that we probably need to get our heads around doing it more frequently ourselves.
Yeah, so SDF is definitely popular, and yeah, I think as Paul says, it's something we're going to be using a lot more of in future.
So Liz, we're only taking questions by posting them, just so you know. So I'm afraid we can't speak. So Natalie, the plan for children who have trauma and a non-cooperative, yeah, it's a really good one. So
yeah,
this is a sticky one for us because our GA service is still suspended and we can't seem to get access to another one at the moment. The plan ought to be GA, but in the absence of that, no, I think Natalie, you've highlighted a real area of concern, and I can't give you a better answer than I'm not sure. In London, I think the Evelina still is in a better position than we are with regards to GA. Yes, with regards to who uses a lot of SDF, maybe I'll chat to Rashid. Maybe I'll chat to Rashid and see if he doesn't mind doing that. Yeah, I thought I might.
And Natalie, I would just
add,
it's not just a trauma. The other issue we're really having for GAs is our special needs, particularly autistic ones, where they're just not able to do clinical holding. And yeah, we're really struggling with those at the moment. Yeah, no, I thought there was actually, a Connect Trainees webinar on SDF last week. So I think, yeah, maybe see if you guys can get your hands onto that one, that recording, because I think that was also supposed to be really good and really informative.
Well, so actually, the most sensible thing would be to, if anyone here is on the Connect group, if that's available, or if there are plans to make that available, then if you give that link, and we can post it out on our Twitter feed and everything, rather than me having to do it if there's something already existing. Because I've heard about
saying apparently someone from Newcastle has been tasked with doing it, so they're already
fine.
Ahead of us.
Good. Yeah, yes. So then I think maybe there's no point in reinventing the wheel. We should get someone else to do it for us. So Furha, yeah, I think if you're in London, try Guys near Evelina. Okay, I think we're getting to sort of local issues. A nice idea about the SDF. I think it was Laura Timms that did it. So if anyone's got, it's a Connect trainee member, if they could find out for us, I think the sensible thing for us just to stick that out there. Susan, anything else you want to say?
Yeah, I think part of this was really to share sort of our thoughts on this, but also to share tips. So if anyone else is aware of any other things that they think would be really helpful, please do share. I think there's no point all of us being in our little silos doing something. We really need to share our ideas and our thoughts for this. So please feel free to contact us or share thoughts. Great.